Hello, my name is Lauren Bouts, and this presentation is titled Supporting Access to Behavioral Health Care for American Indian and Alaska Native Communities in New Mexico, a sovereignty-centered public health perspective. This presentation is based on my final paper for CBHS 6647, Foundations of American Indian and Alaska Native Health. In this project, I examined behavioral health disparities affecting American Indian and Alaska Native, or AIAN, communities in New Mexico, with a focus on access to care and systems-level factors rather than individual outcomes. The purpose of this presentation is threefold. First, I examined behavioral health disparities affecting AIAN communities in New Mexico. Second, I apply historical trauma and self-determination as guiding frameworks to understand these disparities. And third, I center systems, access, and sovereignty rather than framing disparities as individual failure or pathology. New Mexico has a unique context that makes this topic especially important. The state is home to 23 federally recognized tribes, including Pueblo nations, the Navajo Nation, also known as Dene, and Apache tribes. AIAN communities in New Mexico live in rural, tribal, and urban settings, and each of these contexts shapes access to behavioral health care differently. Because of this diversity, effective public health approaches must be grounded in place, history, and tribal sovereignty, rather than relying on a one-size-fits-all solution. Behavioral health disparities among AIAN communities do not exist in isolation. They reflect the cumulative impacts of colonization, forced assimilation, as well as long-standing underinvestment in AIAN health systems. These historical and structural factors continue to shape access to care today. Understanding disparities in this way shifts the focus away from individual behavior and toward the systems and policies that produce and maintain inequities. To help illustrate the disparity I've been describing, I want to briefly contextualize suicide mortality patterns. In New Mexico, suicide mortality rates are higher than national averages overall, and AIAN communities experience the greatest burden. Importantly, these patterns reflect persistent structural inequities rather than individual risk. It is also critical to acknowledge that injury surveillance data are subject to limitations, including racial misclassification and undercounting, which may obscure the true magnitude of disparities. Because of this, these data should be understood as illustrating long-standing inequities rather than providing precise estimates. This figure compares suicide mortality rates in New Mexico with national rates for both AIAN and non-AIAN populations using the CDC Whiskers, WISQARS, data from 2018 to 2023. This comparison shows that suicide mortality rates are higher in New Mexico than nationally, and that AIAN populations experience elevated rates in both contexts. These findings underscore the importance of examining state-level systems and access conditions while situating them within broader national patterns. Again, this figure is intended to provide context rather than to serve as a definitive measure, given known data limitations. The conceptual framework guiding this project integrates historical trauma and self-determination. Historical trauma helps explain how colonization, forced displacement, boarding schools, and cultural suppression have produced intergenerational impacts on behavioral health among AIAN communities. Self-determination emphasizes tribal authority over health systems, research, and definitions of wellness. Together, this framework centers sovereignty and systems rather than individual pathology as the foundation for understanding behavioral health disparities. The literature consistently demonstrates that barriers to behavioral health access for AIAN communities are structural and persistent. These barriers include geographic isolation, transportation challenges, workforce shortages, and chronic underfunding of AIAN health systems. Even when services are technically available, they may not be accessible or acceptable if they are not culturally aligned or community led. A key finding from the literature is the importance of indigenous defined healing models. These approaches understand healing as relational, cultural, and community based rather than purely clinical. Cultural integrity is not an add on to care, it is central to effectiveness. When care aligns with Indigenous values and is delivered in trusted community contexts, engagement and acceptability improve. While Indigenous defined healing models are essential, access focused infrastructure can play a supportive role when implemented appropriately. Culturally aligned telebehavioral health can reduce geographic and transportation barriers, and workforce initiatives such as Project ECHO can support providers serving AIAN communities. However, these tools should function as supportive infrastructure rather than prescriptive solutions, and they must respect Indigenous leadership and community priorities. Based on the literature and conceptual framework, this project highlights three key strategies. First, public health systems should support Indigenous-defined community-led healing models. Second, culturally aligned access strategies such as telebehavioral health can expand access when implemented in partnership with AIAN communities. And third, strengthening workforce capacity through supportive infrastructure can enhance care delivery while respecting tribal authority. These findings have important implications for public health practice. Rather than prescribing solutions, public health practitioners should partner with AIAN communities and tribal organizations. Tribal sovereignty should be understood as a determinant of health. Systems can either reduce inequities or reinforce them, depending on how they are designed and governed. In conclusion, behavioral health access for AIAN communities in New Mexico is fundamentally a systems and sovereignty issue. Addressing disparities requires centering Indigenous-defined healing, respecting tribal authority, and using access-focused infrastructure to support, rather than override, community leadership. This project reinforced for me the importance of cultural humility and systems-level thinking in public health practice. Thank you for watching. I appreciate the opportunity to share this work.